Hello, good afternoon. Today's topic is knee preserving surgeries. So, my name is Dr. Rajasekhar Pappuu. I am an orthopedic surgeon and specialist in knee preserving surgeries. I am also a specialist in diabetic foot and orthopedic infections. So, knee preserving surgeries. So, we mainly do only one procedure, that is high tibial osteotomy. There are different types of high tibial osteotomy. One is valgus osteotomy, one is varus osteotomy. Now, widely we use only valgus osteotomy. That is op medial open bed osteotomy. So why it is joint preservation is more important? What is the role of HTO? It preserves joint, first thing. It also helps in preserving the active lifestyle. If done in early stages, like grade 2, joint can be preserved for about 15 to 20 years or even more. So mainly it is done in patients younger than 60 years. But for me, I do not follow much age limit for these patients. Uh, if they are active and very heavy manual laborers, I would like to do a joint preserve surgery even in elder patients, maybe 65, 70 also, because there are many times when we go to villages, we see people, they are very active. They do very heavy labor work in the field. So they are not the real candidates for knee replacement. So they are the candidates for knee preservation, and most of them will have varus deformity and medial sided OA only. Very rarely you find advanced OA in those patients. So what is the basic principle? So in knee preserving surgeries, the basic principle lies in correcting the abnormal weight bearing axis of the limb. So what is abnormal weight bearing axis? So when you draw a line from center of the hip to the ankle, so this line should pass through the center of the knee. If it is not passing through the center of the knee, that means there is some problem with the alignment. So that's called malalignment or varus valgus deformity. So when you take a draw a line from here, see where line is drawn from center of the hip to the center of the ankle. So here the line is passing to the medial side of the joint. So this patient will definitely have a medial side knee joint pain. So if you take a the tibiofemoral angle, so that will gives you the deformity size. How much is the deformity? How much correction you have to need? So we have to check other angles also here while doing a HTO. What happens when the weight bearing axis is abnormal? So when the weight bearing axis is abnormal, there will be a lot of abnormal biomechanics taking place in the joint, especially when you have a knee joint, you have two sides joint. One is this is called medial side joint, and this is a lateral side joint. So when there is abnormal biomechanics, when there is varus or valgus deformity, the joint gets loaded on one side of the joint. So that will cause more wear and tear on that side of the joint. So most of the times, the other side of the joint is normal because there is no weight bearing on this. The whole load is transferred to one side of the joint. Second thing is, both sides of the joint will get damaged only in very lax joints. So how many types of abnormalities are there? So you have varus valgus abnormality. So when you draw the line, it has to pass through the center from hip to the knee ankle joint. So here what is happening? Here when you draw a line, it's passing from outside of the joint. So it is lateral to your leg. So it is that is called valgus deformity. So here the line passes through in between your legs. In this, see when a line is drawn from center of hip to the center of ankle, here the line passes from between the joints, so between your legs. So this is called varus deformity, that is called valgus deformity. Both of these you will have abnormal biomechanics. So one side of the joint gets loaded more than the other side of the joint, causing wear and tear, increased wear and tear. So once the wear and tear starts, the joint starts the damage starts very faster because the some underlying tissues loses their connective tissue connections between these cells of the cartilage, and they gets separated, and then the damage starts very fast. So then there will be damage more faster the joint gets damaged. Suppose, see, if you take a person, without knee pain, he has lived for 45 years. So that means there is no knee pain. So that means his joint is fine. So he started having pain. That might be grade 1, grade 2. So grade 2, in grade 1, they don't come to us because they will not have much pain. So that pain starts bothering them once in a while, maybe once in 2 months, 3 months. That is when the patient starts having grade 2 OA. So in grade 2 OA, when they come to us after we diagnose that, grade 2, it took 45 to 50 years, suppose it. So from grade 2 to grade 4, it takes less than 3 years or even less. Or if the patients are lucky, it might take more also. So it depends. So the way once it starts, that joint damage has started, it goes like a vicious cycle. So inflammation will be there in the joint. So there will be some inflammatory mediators are produced. There will be synovial reaction. Joint effusion will form. That will cause abnormal nutrition. So because abnormal nutrition, because usually cartilage doesn't have direct blood flow. So it is a avascular zone. Whatever nutrition it gets by diffusion only. So where there is a joint fluid called synovial fluid that contains all the nutrients required for cartilage. So whenever you are moving your joint, so that pressure, that gradient of pressure created between the cartilage between two tibia and femoral cartilages increases diffusion of the nutrient materials into the joint, and then also effusion of the other nutrients which were already byproducts of the nutrition into the joint, and from there they get cleared. So in inflammation, what happens? This mechanism get lost because synovial fluid loses its function and it becomes more thin. Actually, it should be like a greasy like material. So it's no more providing any lubrication in the joint. So it lost its function. So the joint gets damaged more and more, and arthritis accelerates. Damage cartilage damage accelerates, and so the lifespan of joint reduces. So if a person has lived for 50 years, 45 to 50 years for developing knee pain, then after developing knee pain to the severe grade 4 stage, it takes even 2 to 5 years only. It depends on the person to person and the amount of deformity present in the joint. So to this, what happens after this? There will be joint laxity also. So because of fluid swelling, tissues become lax. So starts becoming joints becoming wobbly. So that will cause more damage in turn, and arthritis accelerates. So high tibial osteotomy, what we do in high tibial osteotomy, knee preserving surgeries, that is mainly is high tibial osteotomy. So we do realignment of the joint. So that improves the quality. Quality and effectiveness depends on the timing of the surgery. So whenever you do a surgery for knee preserving surgeries in young patients, if the patient comes to me at a grade 2, if I advise him and do a surgery that time, that will give more life. So if I do it in a grade 3, it will give less period of time. Grade 4, we don't know how many years it might survive. So what are the indications? So secondary degenerative changes. So whenever there is knee pains are many types. So one is osteoarthritis. That is what is also called degenerative osteoarthritis. This is age-related degeneration of the cartilage. So there is another set of knee pains, that is like rheumatoid arthritis, systemic diseases. There are many systemic diseases like you have, what do you say, systemic lupus erythematosus. Then also other Buerger's disease, psoriasis. If a person has psoriasis, that also causes joint damage. Ankylosing spondylitis, where joints get discharged, develops degenerative changes and gets damaged. So in these diseases, we don't do knee preserving surgeries because here the pathology is not in the joint or because of abnormal biomarkers. It is in the blood because of the antibodies which are formed within the blood, which acts against the synovium, which will produce a fluid. Because of that, joint becomes lax, and that causes degenerative changes, and also affects the nutrition of the quality of nutrition of the cartilage. So that leads to the damage of the cartilage. But here, the pain also is because of inflammatory mediators, not because of the byproducts of damage of the cartilage. In osteoarthritis, you have pain because mainly inflammation. That inflammation is like a vicious cycle. So that causes damage of the cartilage. the cartilage particles which are damaged are released into the synovial fluid. That in fact increases the inflammatory reaction, and so that they will have pain. So whenever you give analgesics, anti-inflammatory, they will have some pain relief and all that. But in rheumatoid arthritis, it is your own body attacking your joints. So there is no cure for that. We cannot cure by doing these knee preserving surgeries. So there will be some instabilities also because of late presentation. So all this should be addressed while doing a high tibial osteotomy. So knee preserving surgery is contraindication. So tricompartmental arthrosis, when your patella and also both sides is affected, ligamentous instability. So because of the fluid is produced, joint becomes lax and wobblous. So in those cases, we don't do ligamentous instability. But now this ligamentous instability has become a relative contraindication because now many people are doing ligamentous augmentation. So the lax ligament is augmented. Mainly they will have lax lateral collateral. So these lateral collateral ligaments we have to augment so that will increase the stability, and also we have to increase mainly not only lateral collateral ligament, it is posterolateral complex we have to augment. And another thing is ACL. When most of these people will not have ACL, so if they don't have ACL, we have to do ACL reconstruction, or we have to do slope reducing osteotomy, combined slope reducing osteotomy, where we do high tibial osteotomy. So types of osteotomies, there are many types. One is lateral closed wedge osteotomy and medial open wedge osteotomy and periarticular osteotomy to correct the slope. But now many people are not doing lateral closed wedge osteotomy because there are many complications associated with it, peroneal nerve palsy, and it is also very difficult. There will be shortening of the. So mostly accepted procedure is now medial open wedge osteotomy. So now I'm giving a case where this patient has undergone ACL reconstruction because of knee pain. So when she came to us again with pain after she was operated in 2024, now they operated her, but they have not corrected her abnormal biomechanics. See, in this case, the medial joint is totally narrow, totally narrow. It is almost grade 4, it looks like. So here the lateral joint has opened up. And in this, if you take in the lateral view, the slope is increasing. So that will definitely cause damage to the ACL. So in this case, what we have done osteotomy of the high tibial osteotomy, corrected the alignment. We have done scopy. In the scopy, what we have found out, cartilage is normal, except a small area of raw area where there is grade 4 cartilage defect on the medial femoral condyle. Tibial condyle is good. Medial meniscus is very nice. There is not much problem with the medial meniscus because she has undergone this ACL reconstruction. That ACL reconstructed, that is ACL reconstruction, what they did last time, they did not do replacement of the complete old native ACL was kept inside. But they have done augmented with a graft. So that graft is torn. So now what happens? Because why the graft has failed? Because this slope she is having, posterior tibial slope is high. It is more than 12 degrees. So if it is more than 12 degrees, it is not acceptable. So we have to reduce the slope. In this case, while doing osteotomy, we have corrected the slope also, tibial slope. So we have done here valgus osteotomy with tibial tuberosity osteotomy distalization. Plus also we have done slope correction. So what are the complications of knee preserving surgeries like HTO? That is, complications is non-linear. Sometimes these osteotomy sites don't deal. Loss of correction. So here what happens, many people give weight bearing. I don't give weight bearing because we are doing this surgery for correction of the deformity. So if you give them weight bearing, they will again develop deformity. And also sometimes what happens, when you correct the osteotomy, if they take weight, slope increases, there will be slope formation of the posterior tibials. So that is the reason why we will not allow them to walk. And also sometimes overcorrection. Thinking that the other side is a normal joint, so on X-ray you correct it more. But actually in a arthritis setting, sometimes there will be some sort of problems on the other side also. We should not overcorrect it. Infection at the surgery site. Nerve injury is very rare, only in lateral closed wedge osteotomy only. Arterial injury is possible. If you are in lateral closed wedge osteotomy, in medial closed wedge osteotomy, we are far away from the artery, so there is no problem with the artery. Thank you.